This lecture is kind of designed as a follow-up to the one that we did for the reception triage, but this is actually more targeted towards you guys, you as technicians, okay? With the idea that when all the doctors are busy and it's a crazy day and we got an emergency come in, a doctor doesn't always have to do that initial assessment. So I want to give you guys some tools and a structure on how to assess a patient that comes in emergently to determine, is this something that we can have to see right now? In other words, you have to run and go and yell for a doctor. Dr. Gimbus gave me that, by the way. Or is it something we can have you put in a room, and as soon as one of the doctors are free, then we can have the doctor see you whenever they free up. So that's what the lecture is going to design for us to do. Now, like we said for the phone triage, to know what triage is actually is a French word that means to sort. So what we're trying to do in a triage situation is sort which patients have a higher medical priority, which ones have a lower priority, which ones need to be seen right now, which ones can we wait a little bit before we have to intervene to see them. Now, for an in-clinic triage, our idea is to get as much information about the animal stability in a short period of time. So we really should be not spending much more than 2, 3, maybe 4 minutes during a triage assessment to make certain that we know how they are. So we're not going to go into a whole detailed history. We're not going to do a full exam on them. We're going to be focusing on the most pertinent and the salient facts and the salient physical exam findings so we know exactly how stable this patient is to see if we have to intervene right now or do we wait. Now, when we're talking about triage, the first thing you want to do is get the basic facts from the owner as far as what happened. And this is not going to be a long, drawn-out story of how things transpired over the last 12 hours. It's going to be what happened, how long ago, how has it changed since then, and whenever you assess them, you have to try to keep owners concise. Now, this is one of the few times that you don't want to just let the owners tell their story. You want to be polite, you want to be gentle, but you almost have to ask pointed directions. Okay, what happened? Was he hit by a car? Did he bounce off the car? Did he get run over? Did you see it happen? Did he walk afterwards? Was there any wounds? Did you see him bleeding anywhere? Things like that. Those are the kind of things you want to get pretty quickly and then come back and then start your assessment on the animal to see what it is, okay? Now, whenever you talk to the owner, it's also going to be important to make sure that we can get the initial stabilization treatment done so we don't have to keep interrupting what we're doing or interrupt treatment for the patient in order to get more information. So get initial information. Is it okay for us to put an IV catheter and get initial medications? Maybe if it's a critical patient, do we have permission to start CPR? Things like that for you guys, okay? Now, once we get the animal stable, then we can go back and fill in the gaps in the history and figure out a little bit better what's going on for you. So it's really get the nuts and the bolts of what happened so we have at least a basic idea of how to start and where to go with the patient. Now, when we're assessing the patient, when we finally get the patient into the back and we're taking a look at it, there's really only 4 of the 13 body systems that we evaluate that we have to evaluate. And we did this whenever we did the phone triage lecture. But what we're going to be doing is going through them in a little bit more detail on how to do a physical assessment of these body systems. What's abnormal? What does that abnormalities mean? And so you can assess a little bit better, do I need to go see a doctor now or not? Okay. So just to remind yourselves, the 4 major body systems are respiratory system, cardiovascular, neurologic, and the urinary system. Now, it's important, I want to clarify this in a situation to kind of highlight just how important these systems are and how you assess them. Whenever I was in school, we had a case come in that was hit by a car. And the owners were really worried about the laceration was along the dog's side, okay? That's all they could focus on because it was obvious. It wasn't bleeding that much. It was just a long laceration where you can see the muscle underneath it. But whenever we did our triage exam, we saw that the dog was having difficulty breathing. It was turning purple. Those for owners are sometimes a little bit more subtle. That laceration was not life-threatening. But the lung contusions that happened because of hit by a car that made it have difficulty breathing was much more life-threatening. Another thing that be keeping in mind that even broken bones, those aren't one of the 4 body systems. Broken bones are the musculoskeletal system. The broken bone does not have to be emergently dealt with right now. In fact, surgeons will even tell you that if they've got a closed fracture, that means the bones that are still underneath the skin and there's no open wounds to connect the bones to the outside world, that can wait 2 to 3 days before you set that bone. So you don't want to be focused on the obvious broken bone, but overlook the collapsed lung or the bleeding splenic tumor or something like that that's more subtle, but is much more serious issue that you have to address, okay? So I'll just emphasize, all other body systems are not critical in a triage situation. Doesn't mean you don't address them, but you don't have to address them right now, okay? Now, the only exception to this rule is if an injury or a change in one of the non-critical body systems is able to affect the major body systems. For example, you got a dog that's doing a lot of vomiting, having diarrhea. The gastrointestinal tract is not a major body system. But if they're vomiting to the point where they're losing so many fluids that they're now then dehydrated and going into shock, that now affects the cardiovascular system. That's when you need to start to address it and treat it a little bit more urgently. Okay? Does that make sense so far? Okay, great. Now, evaluation of the respiratory system is relatively simple. There's only a few things you need to know in an urgent triage situation. Respiratory rate, respiratory effort, okay, breathing pattern, and we'll go through a couple of the major breathing patterns that you should be able to identify, in lung sound. So you want to have a stethoscope close by you, pretty easily available, so you can take a listen to some of these lung sounds, okay? Note that I don't have coughing and sneezing as an evaluation of the critical body systems, or of the respiratory system. Although that may be present, the presence or absence of sneezing and coughing is not something we have to worry about in a triage situation. Much more worrisome are the respiratory rate, effort, breathing pattern, and lung sounds, okay? Now, as you guys all know probably, the normal resting respiratory rate is less than 30 breaths per minute. Now, you have to be mindful that when we're assessing them in a triage situation, they're going to be a lot more stressed. So maybe higher than 30. So we always want to interpret that fast respiratory rates or panting breathing patterns in context. You can't just say, oh, it's a fast resting respiratory rate, so I have to be really, really worried, okay? You have to look at it in context to see if there's something that is, okay, I just got a lot of stress or pain, but my respiratory system is really okay, or am I starting to decompensate in congestive heart failure and I'm breathing fast? So you have to look at it in context a little bit. Now, respiratory effort is the force and depth of breathing whenever you go through your breathing patterns, okay? So you have to increase effort on inspiration, you can have increased effort on expiration, or both, okay? So it can be a little bit of different, and depending on the type of abnormality present. Now, just to go through these in a little bit more detail, we should be able to tell the difference by the breathing pattern if the abnormality is in the upper airways, that means in the nose, throat, or extrathoracic trachea. Or is it in the lower airways, which means the intrathoracic trachea, bronchioles, and lungs? Or is it in the pleural space? This is the space between the body wall and the lungs themselves, okay? There's unique breathing patterns associated with each of these that we should be able to identify. And they make sense if you think about it. So for the upper respiratory abnormalities, you're talking about upper respiratory obstructions. When the animal breathes in, if the upper airway, it's going to close and suck down the upper airways, so that you're going to have an increased inspiratory effort. And a lot of times there's going to be difficulty getting air past the soft tissue, so there's going to be a lot of noise. So you're going to have stertor, which is a loud snoring noise, or stridor, which is a kind of a whistling type of a noise for us, okay? So that's what you're going to be able to notice for upper airway disease. Lower airway disease, you get the opposite. The lower airways are in the chest. So whenever the animal inhales, that'll actually serve to open up the airways because of the negative pressure that's generated, so you can have an easier time on an inspiration. But when they go to exhale, that closes down the airway. So if there's any airway disease going on, like asthma or chronic bronchitis or COPD or congestive heart failure, when they go to expire, then it closes off those airways and you have an increased effort on expiration. Now, a lot of times you can hear crackles and wheezes, but you don't hear those with the naked ear. You need a stethoscope on the chest to hear these noises. Crackles, it's obvious. It sounds like crackling newspaper or crackling cellophane, okay? Wheezes are a specific term. A lot of people use wheeze to mean any kind of respiratory disease, but in medical terminology, wheezing is a very specific term, which means on expiration, there's this high whistling sound from the lungs. So that's when we talk about crackles and wheezes for congestive heart failure or lower airway disease. That's what we're talking about, but you hear that with the stethoscope. You don't hear wheezes with the naked ear, okay? Now, pleural space disease, this also makes sense that if you have something, either air or fluid is the most common things that we see between the lungs and the body wall, that then collapses the lungs, okay? So that means that now there's not as much space for those lungs to expand, so you get what's called a restricted breathing pattern. It's common in cats when you get a pleural effusion. Dr. Andrew just had one yesterday doing that. And what you get is fast, shallow breathing because they have to breathe fast because the lungs can't move very much because there's a lot of air or fluid keeping them from expanding fully. So they have to compensate by breathing very fast, and there's not much room for those lungs to expand because they're already collapsed, so that's a shallow breathing pattern. Another thing you might see with pleural effusion is what's called paradoxical respiratory pattern. And it is just what it sounds like. That means on inspiration, the chest actually sucks down or goes and collapses, but the abdominal cavity expands. And on expiration, the opposite happens. On expiration, the chest actually goes out and the abdomen goes in. So it's a paradoxical breathing pattern. This is very typical for things like pleural effusion or pneumothorax, but it can also be a dog that has been having difficulty breathing for a long time, and then the intercostal muscles become fatigued. So all they're doing is breathing with their diaphragm. So when the diaphragm goes down, it'll tend to suck the chest down, but it'll push the abdomen out, and vice versa whenever you go on expiration. Does that make sense? Now, just to kind of help to visualize what some of these things look like, I've got a few videos for this. Now, you guys are all going to recognize this. This is an example of upper airway disease or upper airway obstruction, okay? Can you guys notice that there's a lot of effort whenever it goes to inhale, and there's a lot of noise? I mean, you guys have seen this before, so just real quick, see how he's struggling to inhale, and he's making a lot of that noise whenever he inhales, okay? Okay, good. Now this one is an example of a lower airway disease problem, and you want to keep a close eye on this because it's not as obvious as the upper airway disease. You're not going to hear any noise with this, but you want to look at the respiratory effort whenever the dog exhales. Now there's another dog walking around here, so it's going to be a little bit, come to see around it, but watch the dog breathing. See how inspiration is not that bad, but expiration, you're kind of pushing the air out. See, there's that effort. Sometimes actually an abdominal push. At the end of the expiration, the abdomen pushes a little bit more effort to get every last little bit of air out of the thorax. Did you guys see that? Appreciate that? Okay, good. All right, now this one is a cat with pleural effusion. So we're seeing what's called the restricted breathing pattern, which is fast and shallow. See that? And then this another one is a cat that's had pleural effusion for a while. And we have the paradoxical breathing pattern. So watch the chest and the abdomen closely and see how they move opposite of what you expect. Can I see the chest moving in on inspiration, the abdomen moving out, and on expiration the opposite happens? What's that?
He's straight chilling.
Exactly right. Why he's so calm and why the owners are taking this picture when they're at home and not rushing to the ER, I have no idea. Okay. But this is the paradoxical breathing pattern here. Okay. All right. See if I can get this back up to moving. Okay. There we go. Did that not work? That did not work. Why did that not work? Okay, let's do this. Okay. I might, because this is not coming up now. Oh, there we go. We got it now. Okay. Any questions about the respiratory system? All right. Now, the cardiovascular system, there's a lot of things we can actually assess with the cardiovascular system. We'll go through them one at a time. A lot of you guys have been doing this for a long time. You guys are familiar with all of these things, but I want to kind of go through them in detail because sometimes they don't tell us what we think or we commonly associate with these things. We're going to go through these kind of nice and simple. So we're going to talk about mucous membranes, capillary refill time or CRT, heart rate, heart sounds and murmurs, heart rhythm, pulse evaluation, if there's any bleeding or bruising and how to tell the difference between redness and bleeding and bruising, syncope, which you guys all know means fainting, right? Okay, and the color and the temperature of the extremities, like the paw pads, the tail, the tips of the ears, things like that. Okay. Now, mucous membranes, as we all know, should be pink. Now, for you guys that don't wear nail polish, if you're not sure, look at the pinkness of the thumbnail or your fingernail. That is the pink that the animal's mucous membrane should be. And when you're checking mucous membrane, you have to be careful because it's very easy, especially on a squirmy animal, kind of squeeze a little bit as you pull up the lip to see the gums. If you squeeze too much, you'll actually will blanch them and they'll look pale when really they're nice and pink if you just be gentle with pulling the lip up so you can see that color. I know most of you guys know that, but I know whenever there's the excitement of an emergency situation, it's really easy to kind of really quick and a little bit more excitement and force, you kind of blanch out those mucous membranes than you think. Now, if they're really red, that's called hyperemic mucous membranes. And this is usually typical for what's called vasodilation, where all the vessels are very dilated, so there's a lot of blood that stays right with the mucous membranes. And this happens whenever dogs have what's called hyperdynamic shock. Examples of that would be septic shock or anaphylaxis. Could be when they're really, really excited. Could be whenever they're overheated and they're hyperthermic. So if you see really red mucous membranes, that's what's going on with it. Of course, you know what pale mucous membranes are. They're whenever they're nice and white. Now, that's not always anemia. That's the first thing we think of when we see pale mucous membranes, but can also be decreased perfusion to the periphery. So I've seen a lot of dogs that are in shock that are not anemic, but they have pale gums because they have too little blood volume to get the blood all the way to the periphery. So the body wants to try to compensate for that and shunt that blood to the core of the body to protect the major body organs, the heart, the lungs, the brain, the kidneys, things like that. And then, of course, blue or purple is always abnormal. That usually means cyanosis, which, remember, is low blood oxygen. Not high carbon dioxide, it's low blood oxygen when you see blue or purple mucous membranes, okay? If there's a little bit of a mix, you can sometimes get gray or grayish purple type of mucous membranes. That just means that you've got a combination of pink and cyanosis whenever you see a gray kind of a color. All right, capillary refill time. This is where you put your thumb onto the gums or the lip and then blanch it, and then move your thumb away and count how long it takes for that to pink back up again, okay? CRT actually measures the peripheral vascular tone. It does not measure blood flow. A lot of people think I take that away and the blood's going to flow because of the heart's beating to go right back to where it is. It doesn't. Actually, dead patients that do not have a heartbeat have a normal CRT or can have a normal CRT. So it measures the tonicity of the vascula. Is it dilated, is it constricted, or is it nice and normal tone? Normal is between 1.5 to 2 seconds. I know a lot of doctors will put down less than 2 seconds, but you really should qualify between 1 and 2 seconds because if it's less than 1 second, that usually means it's very fast. It's shorter than what it should be, and that many times can be coupled with the hyperemic or the engorged mucous membranes. And so you get hyperemic mucous membranes with a fast CRT, that can indicate hyperdynamic shock. So not all CRTs less than 2 seconds are normal, just to let you know. Now, if it's greater than 2 seconds, that means you got peripheral vasoconstriction, and that means either shock or hypothermia, things like that going on. Congestive heart failure when you have prolonged CRTs, okay? Is that making sense so far for the CRTs? I remember when I first learned that, I said, well, I always thought it was just blood flow, but it's not. It's actually peripheral vascular tone. Heart rates, you guys know this, normal heart rates in dogs, 60 to 140 with a smaller dog being faster. Cats, they tend to be a little bit faster in general, especially in an in-clinic hospital situation. Actually, at home and rest, their normal heart rates are the same as the dogs, but because they're so easily excitable, in the clinic setting, we say about 120 to 160 is what we expect for this. Now, if they're fast heart rates, you can have just be a very stressed or excited animal, but don't forget about things like hypovolemic shock or congestive heart failure, hyperthermia, anemia, things like that. Tachyarrhythmias, which are abnormally fast heartbeats because a heart disease is not doing, or a heart is abnormal, okay? Slow heart rates, if they're slow, that can be a concern because that could either be a vagal stimulation, and that's common for dogs that have GI disease, central nervous system disease, or respiratory disease. You can get slow heart rates to do something like that. You could have what's called bradyarrhythmias, which are abnormal heart rhythms that are slower than they should be. Things like third-degree AV block can cause a very slow heartbeat. High potassium. We can see this classically in our Addisonian patients. We get a dog that presents in shock, but they have a paradoxically slow heart rate because the high potassium serves to slow that heartbeat down for us. Low body temperature could do it. And don't forget near death. If you have a dog that's really in shock and they're bleeding out and all of a sudden their heart rate starts to drop, but they're not getting more stable, it could mean that they're about ready to die. So keep that one in mind too. Alrighty. Heart sounds, as you guys know, there's 2 heart sounds. Really, there's 4 heart sounds, and I was really excited to know this when I was in school. There's 4 heart sounds, you just can't hear 2 of them. So we normally hear the 2 heart sounds. Now, we hear the lub-dub. Now, the lub is whenever the heartbeat contracts. The very first part is called systole, and that's where the atrioventricular valves close. And then the dub is whenever the heart starts to relax, and you got what's called the semilunar or the the aortic and the pulmonary valves to close. Now, just kind of give you an example of what this is like. I'm going to start over here on the right side. This is systole. For some reason, this picture is backwards. So this is where you hear S1, which is the lub sound. And this is going to be during contraction. So here are the atrioventricular valves right here, and they're going to be closed whenever the ventricles squeeze, going to serve to close these, but open up the aortic and the pulmonic valves, okay? Now during diastole, or whenever the heart contracts, that's where you hear the dub, which is S2. So the ventricles now are going to be expanding and getting larger. So then the AV nodes open, but then the pressure that's in the pulmonic and the aortic vessels, they're going to serve to close the semilunar valves. So you hear the dub. So you hear lub, dub, lub, dub, lub, dub. Does that make sense? Now, if you hear more than 2 heart sounds, that's not normal. Remember, there are 4 heart sounds. So sometimes you do hear in abnormal states S3 and S4. S1 is at lub, S2 is the dub, but then you get S3 or S4. You can sometimes hear those whenever there's heart disease present or a volume overload and things like that for us. Also, if you get an animal that has really premature abnormal beats, it happens so close to the previous heartbeat, it sounds like another heart sound, and it terms another heart sound. Now, if we hear more than 2 heart sounds, we call this a gallop rhythm. So when we term a gallop rhythm, this is what it is. And when we characterize it, we try to see, okay, now we have an audible S3 or an audible S4 or a split heart sound. Those can be hard to distinguish, but so it's still usually enough to say there's a gallop rhythm. Gallop rhythms are almost always abnormal. Now, if you have a dog with dull or a cat with dull heart sounds, that could be for a few different reasons. You can have it because there's something between you and the heart that's making a softer sound get into the stethoscope. So things like pericardial effusion, so fluid around the heart. Pleural effusion can do something like that. We can also have just fat dogs have dull heart sounds, or we can have these large lipomas you commonly see around the chest. If you have large lipomas, there's going to be more tissue in the way of you hearing those heart sounds. So these can cause some dullness to the heart sounds, okay? Alrighty, good. All right, now heart murmurs. In a triage situation, it's really important to know if there is a murmur there and a little bit about where it is. Is it on the left side? Is it on the right side? If it's on the left side, is it down by the apex of the heart, or is it up by the base of the heart? And is it during systole, or is it diastole, or is it a continuous murmur, which means present during systole and diastole? So you don't have to spend a lot of time listening for the murmur, but it is important to listen for the 4 different heart valves and left and right sides, because some murmurs are louder on right than left in certain situations. Some are loud, most are louder on left than right. Some can be continuous, but you don't see that or hear that until you're up at the base of the heart. So it's going to be worth it to take a couple of seconds, kind of scan your stethoscope around the left and the right side. Now, just kind of give you an idea where these might be. I've got an image here where this is the left side of the chest over here. So down here at the apex, which is the lower part of the heart, near the costochondral junction, is going to be your mitral valve. And then you're going to have the pulmonic and the aortic valves up here, way up underneath the armpit. You have to go way up underneath the armpit to hear these. And then on the right side, you have the tricuspid valve over here. So the mitral and the tricuspid valves are apical. And then the pulmonic and the aortic are what's called basilar. So whenever you hear me say those things on the exams, that's what I'm referring to. That's where they are. That's where I'm hearing it. Where you hear the loudest sound, because some murmurs will radiate to different areas of the chest. So you always characterize a murmur by where it is the loudest. It's called the point of maximum intensity. Okay, so that's what we do when we characterize the murmurs for you. But again, in a triage situation, you just have to say there's a murmur, where it is it apical, basilar, is it systolic, diastolic, or is it continuous? Just by so you know, diastolic murmurs are really soft and hard to hear, so you probably will never hear a diastolic murmur in a triage situation. Okay, now heart rhythms in a triage situation, you just have to know, is it regular or irregular? Keeping in mind that regular does not mean normal, and irregular does not necessarily mean abnormal, okay? So we have heart rhythms like supraventricular tachycardias or VTAC or third-degree AV block. These are very regular rhythms, but all of them are very abnormal. Similarly, whenever you listen to a dog that is very athletic, you can have the heart rate increase and decrease associated with respiration, and that is a variation of normal. Sometimes you can have some irregular with it if there's what's called a wandering atrial pacemaker. Now you need an ECG to know if that's there, but these are irregular rhythms, but they're considered normal in dogs. So don't always think in your mind, oh, it's an irregular rhythm, it must be abnormal, or it's a nice regular even rhythm, it must be normal. Those don't always correlate, okay? Now whenever you're listening to the heart, in a triage situation, it'd be good for you to have the other hand somewhere to feel a pulse, femoral pulse or a dorsal pedal pulse, things like that. Because if there is an irregular heart rhythm, it's important to know, does every heartbeat generate a pulse, or are there some missing pulses called pulse deficits? Okay, so whenever you are listening, you kind of listen with one hand with the stethoscope, the other hand feel for the pulses and see if there's a correlation between every single heartbeat. Okay, all right. Now for pulses, this is another thing that kind of people misinterpret. We often say, especially in surgery, the blood pressure looks low, feel the pulses, see what they're like. Actually, we're not feeling blood pressure when we're feeling pulses. What we're actually feeling is the stroke volume of the heart. The stroke volume means how much blood is pumped out of the ventricles with each heartbeat. Okay. Now, it can be an indirect measure of blood pressure. So if we have a more central artery, like the femoral arteries, if we can feel those, usually we have the blood pressure, what's called the mean arterial pressure, not the systolic, but the mean arterial pressure greater than 60 or at least 60. Now that's important because you need the mean arterial pressure of at least 60 to be able to perfuse the heart, lungs, kidneys, and brain. Okay, so you want to be sure you can always feel a femoral pulse. Now, if you can feel a peripheral pulse, these are the median arteries up in the front pause or the dorsal pedal on the back pause. If you can feel those, then your mean arterial pressure would be closer to 90, which is a much more normal and happier mean arterial pressure. So you can have an indirect assessment of blood pressure when you feel pulses, but really when you're feeling a pulse, you're not feeling blood pressure, you're feeling the stroke volume of the heart. So that means whenever we're finding abnormal pulses, we have a decreased pulse quality. What we're feeling as a situation where there's decreased blood being ejected from the heart with each beat. So things like hypovolemic shock will give you poor pulses because there's less blood in the heart at the time. Very fast heartbeats can give you poor pulses because when the heartbeat is very fast, there's not that much time for the heart to fill back up with the blood. So it's got an incomplete feeling, so that that pulse that you feel has a decreased pulse quality associated with it. Hypothermia or congestive heart failure, where the heart is kind of weakened and it's not pumping with as much strength in those situations, so you can get poor pulses in those situations. Now, bounding pulses are something that can also be felt, and that's where you're not feeling very much normally, but then you get this big bounding feel whenever the heart does beat. And this can happen whenever there's a lot more blood being leaving the heart. So if there's a long pause between the heartbeats, that the heart now has a lot more time to fill up, and as a result, it's going to eject a lot more blood whenever it does beat, so you're going to feel a bounding pulse. It can also be seen with low heart rhythms because that's the same thing. It's got a long time between heartbeats to be able to get more blood to pump out each time. Hyperdynamic shock is a situation you can also feel bounding pulses, not so much because there's a lot more blood being pumped out, but the blood vessels are dilated. So it's going to feel like a bounding pulse because you're not going to feel that resting pulse or resting tone very well. But whenever that loose flaccid artery now is going to get blood flow through it, it's going to bound right through it because it's nice and flaccid. So it's going to feel bounding for you. If you have incompetent semilunar valves, these are the valves that hold the blood back in the aorta whenever the heart is in relaxation. If you have them incompetent, blood will flow out of it, so you'll have actually a lower diastolic pressure, a lower vascular tone, so whenever the heart does beat, it's going to feel bounding. So there's going to be a lot of situations you're going to find a bounding pulse, but it is also abnormal. It should be nice and even and strong when you're feeling the pulses. But remember, you're not feeling blood pressure, you're feeling how much blood is ejected from the heart, or the stroke volume. All right, bleeding and bruising, this is also something very easily and quickly assessed. If there is any bleeding or bruising present, if there's bleeding, how much, and is it venous or is it arterial? Remember, venous blood kind of oozes, arterial blood squirts. Okay, we've all seen that in surgery when we accidentally hit a bleeder. Okay, if there is bleeding, you have to try to quantify it somehow. And remember, some blood loss can look very dramatic. I know we've all experienced the happy tails or the lacerated ear flaps, and they're just everywhere. It looks like a massacre. But when we actually look at the total volume blood in each of those droplets, it's really not very significant. So you want to try to quantify it, but keep in mind, some blood loss can look very dramatic when it's really not. The other thing to keep in mind is some very significant blood loss can be hidden. So if you've got a hemothorax, blood in the pleural cavity, if you have a hemoabdomen from a bleeding tumor, or if you have a very large GI bleed, or if you have a broken bone that has a large amount of bleeding into the muscles. These are areas that you can have a very significant blood loss, but you're not going to see it very obviously on the surface. So don't forget to look for these if you have signs of shock, which is fast heart rates, poor pulses, poor gum color, prolonged CRTs, things like that. Okay. Now, if you have bruising, remember there's two main ways that we characterize bruising. One is called petechia, which are small little pinpoint or punctate type of bruises. Or then you have ecchymosis, which are just large, widespread bruises for us there, okay? Now, sometimes you can have an animal that has a very inflamed area of skin. And when you look at it, you're not sure, is that something that is a bruise or is that just a very inflamed area of skin? So you can use a technique called dioscopy. We don't use it very much here. Sometimes just kind of try to blanch it. But dioscopy is a little easier for you to see, where you take a slide and you just put pressure on the area that is red. If it blanches, then it's just hyperemic. It's not a bruise. If it doesn't blanch and it stays red, that means that there's free blood outside the vessels, and that's a bruise. Okay? Now, just to show you what that looks like, here is a picture of a dog that has a really deep red spot on its skin. So it's hard to tell just by looking at that, is that a bruise or is that just a really inflamed area of skin, like a hot spot? So what they did is they got a slide, put some pressure on it. You can see how that blanches out. Okay? Over here, you can see there's a lot of patchy redness. So they put the slide here, and you can see that patchy redness does not go away with pressure. So this is bruising. This is just hyperemia from an inflamed skin. And so don't forget dioscopy if you want to just reach for that real quick to see, is there evidence of bruising for you? Okay. Now, syncope, it says basically fainting. Now, what happens with fainting is that there's a loss of consciousness because there's a lack of blood flow to the cerebrum, the conscious centers of the brain. It could take actually a long time of no heartbeat before that happens. A good 6 to 10 seconds without any blood flow before an animal will faint. So you can get some long 2-3 second pauses, and they can look at you right as rain. So it has if you're seeing syncope, that means there's a long pause between heartbeats, and that can be very, very scary. A lot of times this happens because of heart disease itself. And a cardiologist sometimes calls a syncopal event as an aborted sudden death, which means the dog actually died for a little bit, but the heart started up again all by itself. So it aborted dying for a minute. So cardiologists call them aborted sudden death syndromes. Now, if you do have very, very slow heartbeats, remember all the things will cause slow heartbeats. So heart disease, bradyarrhythmias, or slow heart abnormal rhythms. Vagal events could do something like that. So you commonly see a dog that will just vomit a whole bunch, all of a sudden just faint and then come back. Now, collapsing episodes and faints can sometimes be confused with a seizure. A lot of people call, say, my dog just had a seizure right after he coughed or vomited, and it's really a fainting spell. They can look very different, and in some cases, I know that there's been board-certified cardiologists and neurologists going back and forth wondering, is this a seizure event or is this a fainting spell? So don't feel bad if you can't really tell the difference. One of the key differences, though, is fainting spells, they go unconscious, and then they wake up and they're right as rain, okay? For a seizure event, they need a time for the brain to reset, that post-ictal phase. So seizures always have a post-ictal phase. Sometimes it's subtle, so you don't always know if it's there or not, but they have a post-ictal phase. But fainting spells, they wake up and they're right as rain, okay? All right. Now, the color and temperature of extremities, we've all done this where you see the paw pads, especially cats, you get them to be cold or pale and things like that. And if they're cold and pale, that usually means decreased blood flow. So hypothermia, shock, anemia, or a blood clot to the leg, which interferes with blood flow to that leg. Now, if you have cyanotic paw pads, then that indicates that there's blood stasis and there's a decrease in the oxygen in that blood that is in that spot. Sometimes it can be segmental. I've seen animals just one paw pad when they've got a venous clot and the veins can't drain that area, and it gets swollen and it's blue because the oxygen that's there can't leave, so it gets all used up and they become cyanotic. Okay, or it could be just if you have overall cyanosis, blue tongues. Sometimes they'll have blue paw pads too, especially cats where you can see them to be pink for us. Okay, so those are all the ways you can assess the cardiovascular system. Now, neurologic system. This is usually a very quick assessment. You can almost tell everything you need to know with a neurological system at a quick glance. The animal's mentation, are they bright and alert, are they depressed, are they stuporous or comatose, are they having a seizure or not? And also, what's their posture? How are they oriented in space? And I'll talk about that in a minute, a few abnormal postures to look at. And can they walk? And if they can walk, what is their walking ability? So this, although I'm going to spend a few minutes on it, it's actually a very quick system to assess. You almost know that instantly, okay? So mentation, remember that when we talk about mentation, there's 4 levels of mentation. Bright and alert, which is obviously normal. Then you have depressed, dull, and obtunded. If you hear dull or obtunded, that means the same thing as depressed, okay? Now, this one is something that I really focus on, and one that, if especially over the phone or I'm not sure, helps me to assess how critical a patient is when all else is in doubt. The more depressed a patient is, the more sick it is. So in other words, if I've got a dog that's vomited 12 times and another dog that's vomited 12 times, but the first dog is running around bouncing and happy, and the other one's just kind of laying there like a bump on a log, I'm going to much more quickly jump on the one that's depressed than the one that is bouncing around, even though the amount of vomiting and fluid loss is the same between those two patients. So the level of depression can give you a better indication, if you're in doubt, how sick or how critical the patient is. Stuporous mentation means that they're pretty much non-responsive unless you do something that hurts them. Okay, you pinch their toe or something like that. Now, comatose means that they're unresponsive even whenever there is a painful stimulus applied. So the only way to know between stuporous and comatose is by putting something or doing something a little bit painful to them, like squeezing a toe or something like that. Now, seizures, we all know what seizures look like, and we all know that there's 3 phases to seizures, but just to review them, there's a pre-ictal, or what's called aural phase, okay, or what's called pleurodromal phase sometimes, it could all mean the same thing. This is the phase where animals feel that something's not quite right, and sometimes they'll have a change in behavior. So for owners who have dogs that seizure frequently, they can sometimes will pick up on a change in behavior and anticipate a seizure might be coming up pretty soon. And this can happen minutes to hours before a seizure event happens. Then you have what's called the ictal phase, and this is where they're unconscious and they're having the tonic-clonic movements all over their body. Then the post-ictal phase, which I think of as the brain resetting itself to becoming more normal. This is extremely variable both in how it presents and how long it can be. It could be where the animals are just a little bit disoriented, they can become aggressive, they can be blind, they can be uncoordinated, they cannot recognize their owners sometimes or get confused very easily. And this can happen anywhere from a few minutes to a few hours after a seizure event occurs, okay? Remember, the post-ictal phase is one of the distinguishing characteristics between a syncopal event and a seizure, okay? Now, in a seizure event, although there are 3 phases, it's only the ictal phase, the time that they're unconscious and doing the tonic-clonic movements, that we have to worry about it. So when we have an animal that's seizure, but they're not seizure when they come in, and you ask the owner, how long did that occur, that can give us a lot of information. But keep in mind, especially for first-time seizure owners, that is a very scary event. And they will commonly over-exaggerate how long that seizure happened. I've seen a lot of dogs will have a 20 or 30-second seizure, and the owners come in and say, "I was a 10-minute seizure." They really over-exaggerate how much it is, and sometimes quite a bit over-exaggerated. So whenever I tell people to time seizures, I tell them to do it by a watch, because that will eliminate that subjective tend to over-exaggerate how much it is, okay? Now, when you see an animal that seizures, if you get in the history or you know that they're diabetic, or if you have a pediatric patient come in seizuring, that may be due to low blood sugar. So it's never wrong in a triage situation. Even before you run to get a doctor, get a quick spot blood sugar checked on that just to see if that is a hypoglycemic seizure, because that is treated differently than any other seizure event. And it can give a doctor a lot of information to really hop on the right path pretty quickly for you guys, okay? All right, great. Now, the neurologic system with the posture, this is how the animal's oriented in space. So basically, are they standing, are they sitting, or are they recumbent? Now, if they're recumbent, are they on the side? And you want to say which side it is, right lateral recumbency, left lateral recumbency, or are they sternal, which means they're up on their chest, but their back legs are off to the side, okay? Now, if you have them recumbent, if they can or they will move, that's going to be an important thing for us to know, because some recumbent animals are that way because they are paralyzed or they're so weak that they cannot stand. Now, in a triage situation, it's not important to make them do that, but if they're recumbent, you have to try to discern, can they stand or they just not want to stand, okay? Now, you can also take a look, see if there's any curvature of the spine. If you've got a dog that has intervertebral disc disease, a lot of times you guys heard me say there's kyphosis of the thoracolumbar spine. Kyphosis is basically a hunching of the spine. The spine from the head to the tail is arched dorsally, arched upwards, okay? And that's because they're painful. So that's called kyphosis. And that would be helpful for us in a triage situation, because if they're kyphosis, that means that they can have either abdominal or back pain, and we can narrow down our focus right there right away. Lordosis is the opposite. That's when you go from the head to the tail, the spine is actually dipped down. And a lot of times that occurs whenever there's muscle weakness or chronic atrophy of the muscles around the spine, and it kind of goes down. And it's common in horses. They call it swayback in horses, actually. You get the lordosis. Scoliosis is curvature in the opposite direction. So we talked about curving up or curving down. Scoliosis is curving side to side. So the spine, when you go from the head down to the tail, if you're upright, the scoliosis goes like an S shape, or it's just curved from side to side, not up or down, or dorsal or ventral. Does that make sense? Now, I also want to distinguish between head tilt and head turn. We all have heard these terms a lot, but I want to make sure we don't confuse it. Head tilt is where the head ear is, one ear is held lower than the other, but the nose is facing straight. Okay, that's a head tilt. Common for vestibular dogs to have a head tilt, usually towards the side that they're dizzy towards. Okay, a head turn is the ears are level, but the nose turns. So the head is turned side to side. And that can happen when there could be neck pain, or if there's a problem with the what's called the accessory nerve, which is one of the cranial nerves that innervates the muscles to the side of the neck. So it can distinguish between a head tilt versus a head turn. Okay? And then walking ability. Like I said, it's not important to make a dog walk in a triage situation, but if they can walk, you want to know to see how do they walk. Do they have a normal strong gait? Are they clumsy? Are they weak? Or are they paralyzed? Okay, everybody saw the paralyzed dog with the back end where they just kind of, back legs are scooched out in front of them. They're just kind of supporting themselves with their front legs. So that's another important thing. Now, just to kind of be a little bit more clear with terminology, the medical suffix for paralysis is plegia, okay? And the suffix for weakness is paresis, okay? Now, if you have the prefix of para, that means both back legs. So the paraplegic is the one I just talked about. The back legs scooched out in front, and they're just kind of sitting there with their back hunched, okay? That's paraplegia. Hemiplegia means that you got two legs, but they're on the same side, that are either weak or paralyzed. So paraparesis means that the right front and the right hind leg are weak, okay? Or the left front and left hind. So right hemiparesis, left hemiparesis. Right hemiplegia means that they're paralyzed, that they can't move, but both on the same side. And then you have what's called quadriplegia, which means all four limbs are affected. Now you're probably asking me, well, how come we only say with para to the back legs? What if just the two front legs are involved? That never happens because the central nervous system has a hierarchy, and anything that is behind an abnormal lesion is going to be abnormal. So you never get the front legs to be abnormal with the back legs to be normal. It just doesn't happen because if the front legs are abnormal, everything behind them are also going to be abnormal as well. So you never get a front limb paraplegia, okay, or a front limb paraparesis, okay? Now, if they are clumsy and they're just clumsy and ataxic, I want you guys to realize that there's actually three different ways that they could be ataxic, okay? One is called proprioceptive ataxia, then you have vestibular ataxia, and then you also have cerebellar ataxia. Dr. Wells is really good on cerebellar ataxia because he's got so many cerebellar cats that he knows what they look like. But the ways it distinguishes between those is by looking at the animal, see what goes off center first. For proprioception is the sense that we know where our hands and our legs are without having to look at them, okay? So if they don't have that sensation, the animals are going to have their feet off to the side and it pulls their spine or their trunk with it. So the legs are the main ones going off to the side whenever they are proprioceptively ataxic. For vestibular ataxic, they know exactly where their feet are, but their balance is off. So the trunk is going to go off to the side and it's going to pull the legs with it. Now, on a neurologic exam, once we evaluate them more closely, if we have a dog with proprioceptive ataxia, you're going to have proprioceptive deficits. They're not going to knuckle right, they're going to hop wrong, they're not going to be able to hemi-walk and things like that. But if you have a vestibular dog that has vestibular ataxia, they have normal postural responses. They're going to correct their feet properly. They're going to hop properly, things like that. So that's another way you can help to distinguish between those. Now, cerebellar ataxia is when the cerebellum is abnormal in some way. Now, the cerebellum is responsible for coordinating our movements, not initiating them and not necessarily telling us where our legs are, but coordinating them. So for these, we have what's called hypermetric movements. They're really exaggerated, floppy movements. A lot of times they can't coordinate things that they try to move, so they have what's called volitional tremors. The classic example is that whenever they go down to eat or drink, their head bobs and bobs and bobs until they could get to the water or the food like that for us. Or they can have what's called a truncal sway. When they're just standing there, they just kind of sway back and forth. And that's because their cerebellum is not coordinating the tone of the muscles properly, and they have the truncal sway. So if you see any of that, that's from cerebellar ataxia. So if you see an ataxic dog, you can use these hints to help to determine what type of ataxia they have. Okay, lastly, the urinary system. This in a triage situation really is limited to can the animal urinate, okay? So this is one of the more hidden systems. It is critical, but if the animal cannot urinate, we have to hop on that really quickly. That is an urgent situation. Things like acute renal failure or avulsed ureters or ruptured bladders, those are also critical as well. But in a triage situation, you're not going to be able to assess those things. Okay, it's going to be more, can they urinate or not? So in the history, you have the owner say, my cat has been straining and straining, and there's nothing coming out. Now, just from that alone, you don't know, is the animal blocked? Is that little fella blocked? Or does he have such inflammation with his bladder that he just has no urine left, but he feels like he's got to go anyway, so he still keeps trying to strain and strain. So that's where feeling of bladder is going to be important. As you all know, a blocked bladder is large, firm, and painful. Do be mindful that the firmness is a better indicator of being blocked than the size, okay? I've had, in fact, my own cat years ago, he came up to me and he tried to pee right in front of me and he was not productive. And it was the first time he did that ever. And I felt his bladder, and it was still small. It was only not that big, but it was very hard and firm. And here he is just very recently blocked. So recent that he did not had time for that bladder to fill up completely, okay? So go judge the firmness of the bladder more than the size of the bladder if they're blocked. And also, there's been a lot of cats who've been here in the hospital for a day and they just don't pee. Their bladders get really big, but they're still soft and they're not that hard, firm texture that's painful. So again, texture is a better indicator if they're blocked than size, but usually both go hand in hand for you guys, okay? Now, if you feel the bladder and it's small, then you know they're not blocked, but there could be a lot of bladder inflammation anyway. And so that bladder still can be firm and it can be sometimes a little bit tender as well. But this is more indicative of things like stones, polyps, tumors, urinary tract infections, things like that whenever you get the small bladders, okay? So I'm talking like really small. But if you have a medium size to large bladder and it's really hard, that can be a blocked cat more so than just always has to be a big bladder, okay? Does that make sense for you guys? Okay. Now, when we're looking at all these things, I went through a good 40, 45 minutes how to go through the major body systems and what we do assess, what our abnormalities mean, what they don't mean, things like that. But in a triage situation, remember, we're going to do this over a 2 to 3 minute period. So it looks like the animal comes back. You immediately know by just looking at them, they're bright and alert, or they're depressed, or they're able to walk, or they're not able to walk, or they're paralyzed. So neurologic system is right there right away. Then you get them on the table, you take a look at their breathing pattern. There's a nice normal effort. And then you come up, you look at their mucous membranes to see are they pink or not, do a CRT, get your stethoscope, take a listen to the heart and feel for the pulses to see if the heart rate, the heart rhythm is like, and they've got a pulse if they have the heartbeat and heart rhythm. And then you can listen to the lungs if there is abnormal respiration. And then if there's any concerns about the bladder, then you also go back and feel for the bladder right away. So again, I'd spend a lot of time going through these things, but when I just, as you can see, going through an example of what a triage physical exam looked like, it is really, really quick, 2 to 3 minutes for you to get through all that information. And when you're assessing these things, it's not always just one thing is abnormal and you got to panic. You got to look at it in context. And I can go through it all day, all the different ways that these things can be abnormal when you have to be excited. But in general, the more severe or the faster an onset that a certain sign or abnormality is, the more serious it is. So you have to be really concerned. And so like I said, you got the dog that is vomiting 12 times in an hour period. That's much more worrisome than, say, the dog that's vomited 12 times in 2 months. Okay, so the speed of onset is a concern. So if you have an animal that goes from bright alert and it's all of a sudden depressed, then you have to be really concerned. Or you have a really, really fast heart rate and they're depressed. So it's a lot of times looking at the abnormalities and looking at them together to know, okay, this patient looks to be at all really, really critical. This patient is something that's really, really stable, and we can wait till the doctor gets to be free. Now, it never is wrong. If in doubt, always go get the doctor anyway. Okay, it's never wrong to do that. It's always best in an emergency situation to err on the side of caution for us. Okay, don't forget about the client concerns. If the owner thinks it's an emergency, you have to address their concerns urgently as well. Even if the patient, once you do your triage exam, is still relatively stable. Now, if the animal is stable, you address the owner's concerns urgently, but you treat the animal based on its stability if there is something really busy going on at the time. Now, if there's nothing busy going on, sure, even in a stable animal, the doctors can assess and address the owner's needs urgently and things like that. But don't forget about the owner's concerns because in an emergent situation, they're going to be very excited. And one of your jobs is to calm them down and reassure them that everything's going to be okay and your animal's needs are going to be met. Okay? Alrighty. Any questions about anything for me?